You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about Ebstein's anomaly, double-chambered right ventricle, tricuspid valve dysplasia, and pulmonary valve hypoplasia. So it's an episode about several right-sided lesions. We'll start with Ebstein's anomaly. Ebstein anomaly is a teratogenic effect of maternal lithium ingestion. Normally, the tricuspid valve leaflets form from the endocardial layer of the heart, but in Ebstein's anomaly, this process is halted, so the tricuspid leaflets do not develop. On imaging, the anterior leaflet of the tricuspid valve will be large and sail-like. Tricuspid regurgitation of varying degrees is usually evident. The right ventricle will be, quote, atrialized because the true orifice of the tricuspid valve is very deep in the RV, meaning very close to the apex. The more severe the displacement, closer to the apex, the less functional the right ventricle will be. There will be rotational displacement towards the RV outflow tract. Specifically, when we talk about apical displacement of the septal leaflet of the tricuspid valve, we are talking about more than 15 millimeters non-indexed or more than 8 millimeters per meter square indexed to BSA relative to the mitral valve. Normally, the tricuspid valve leaflets are lower, closer to the apex, than the mitral valve. In Ebstein's anomaly, they are exaggeratedly lower, closer to the apex. Remember, this is the opposite of atrioventricular septal defect, where the mitral valve septal attachment is apically displaced and lower to the same level of the tricuspid septal attachment. Ebstein anomaly results in apical displacement of the posterior and/or septal tricuspid valve leaflets, but not the anterior leaflet. The loud click heard on auscultation is related to the sail sound emanating from the large anterior tricuspid valve leaflet as it billows backward in systole. About half of patients with Ebstein anomaly have either an atrial septal defect or a patent foramen ovale, and an evaluation of exercise oxygen saturations is recommended. The high pressure in the right atrium from tricuspid regurgitation will cause right-to-left shunting through the ASD or PFO, leading to cyanosis. MRI is important to assess the size of the residual RV. Other manifestations: 1/4 of patients with Ebstein anomaly have an accessory conduction pathway, typically a right-sided Wolff-Parkinson White pattern on ECG. Atrial arrhythmias, particularly AFib and A-flutter, are common in Ebstein anomaly. Concealed accessory pathways are common in Ebstein's anomaly and may coexist with manifest accessory pathways. In addition, pre-excitation may be present but difficult to appreciate on the surface ECG. Tricuspid valve surgery can hinder transcatheter access to right-sided accessory pathways and the slow pathway in AV node reentry, such that it may be reasonable to assess for arrhythmia substrates and proceed with catheter ablation if identified before surgery. Therefore, the 2018 Congenital Heart Guidelines say electrophysiological study with or without catheter ablation can be useful in the diagnostic evaluation of adults with Ebstein anomaly and ventricular pre-excitation, but without supraventricular tachycardia. That's a Class 2A recommendation. In adults with Ebstein anomaly, electrophysiological study and catheter ablation, if needed, is reasonable before surgical intervention on the tricuspid valve, even in the absence of pre-excitation or supraventricular tachycardia, Class 2A. Catheter ablation is recommended for adults with Ebstein anomaly and high-risk pathway conduction or multiple accessory pathways, Class 1. Adults with Ebstein anomaly and ventricular pre-excitation often have multiple accessory pathways, which are associated with a higher risk of sudden cardiac death. Surgical interruption of accessory pathways is largely reserved for patients who have failed attempts at catheter ablation. There is no special association between Ebstein anomaly and systemic hypertension. Now let's go over when to intervene. Intervention is indicated if the patient with Ebstein anomaly develops signs of heart failure or a decline in exercise capacity. Specifically, the 2018 Congenital Heart Guidelines say surgical repair or reoperation for adults with Ebstein anomaly and significant tricuspid regurgitation is recommended when one or more of the following are present: heart failure symptoms, objective evidence of worsening exercise capacity, progressive RV systolic dysfunction by echocardiography or cardiac MRI. That's a class 1 indication. The guidelines also say surgical repair or reoperation for adults with Ebstein anomaly and significant tricuspid regurgitation can be beneficial in the presence of progressive right ventricular enlargement, systemic desaturation from right to left atrial shunt, paradoxical embolism, and/or atrial tachyarrhythmias. That's a class 2A recommendation. Bidirectional superior cavopulmonary anastomosis or Glenn anastomosis at the time of Ebstein's anomalies repair may be considered in adults when severe RV dilation or severe RV systolic dysfunction is present, and when left ventricular function is preserved and left atrial pressure and LV end diastolic pressure are not elevated. That's a class 2B recommendation. Intervention is surgical repair or replacement of the tricuspid valve and depends on how much residual right ventricle remains below the repaired or replaced tricuspid valve. Transcatheter interventions such as TriClip are not yet available for Ebstein anomaly. If there is an atrial septal defect, it can be closed during the time of the tricuspid valve surgery. Now let's talk about double-chambered right ventricle. Double-chambered right ventricle refers to the presence of muscle bundles in the mid-RV that separate a proximal high-pressure right ventricular chamber from a distal lower-pressure right ventricular chamber. There will be elevated velocity of the TR jet due to elevated proximal RV chamber pressure. MRI would show the obstructive RV muscle bundles. Double-chambered RV can be misdiagnosed as pulmonary stenosis or pulmonary hypertension due to incomplete imaging or physical examination assessment of an RV outflow tract murmur. Since the diagnosis of double-chambered RV is uncommon, it can be unrecognized and present late in adulthood. Double-chambered RV is not infrequently associated with a restrictive ventricular septal defect. VSD may communicate with a higher or lower pressure chamber in the right ventricle with resulting differences in shunt direction and flow characteristics. In patients with severe gradient through the right ventricle, the VSD may be associated with right to left shunting if proximal to the obstruction, or associated with left to right shunting if distal to the obstruction. Repair. Surgery for double-chambered right ventricle involves transatrial or transventricular resection of obstructing muscle bundles and VSD closure if present. Occasionally, patch enlargement of RV outflow tract may be necessary to adequately relieve obstruction. The 2018 Congenital Heart Disease Guidelines say, surgical repair for adults with double-chambered right ventricle and moderate or greater outflow obstruction is recommended in patients with otherwise unexplained symptoms of heart failure, cyanosis, or exercise limitation. That's a class 1 recommendation. Surgical repair for adults with double-chambered right ventricle with a severe gradient may be considered in asymptomatic patients, class 2B. Now let's move on to two short sections, tricuspid valve dysplasia and pulmonary valve hypoplasia. Tricuspid valve dysplasia mimics Ebstein's anomaly, but there is no displacement of the annular hinge points of the tricuspid valve. Instead, you have thickened tricuspid valve leaflets and chordal shortening with incomplete coaptation of the tricuspid valves. All tricuspid atresia must have some type of atrial communication to decompress the right atrium and allow for egress of blood from that chamber. Tricuspid valve dysplasia has to be surgically repaired. It can't be percutaneously repaired. Now, pulmonary valve hypoplasia. Alagille syndrome's main cardiac manifestation is pulmonic valve stenosis or hypoplasia. 16% of Alagille syndrome also has tetralogy of Fallot. The syndrome is caused by a mutation in the JAG1 gene or Notch2 gene. It results in absence of intrahepatic bile ducts, causing progressive liver disease and chronically elevated bilirubin and cholesterol. Other features of Alagille syndrome are pancreatic insufficiency, basilar artery aneurysm with increased risk of intracranial bleeding, butterfly-shaped vertebrae, and embryotoxin, and opaque ring in the cornea. Now let's go over right ventricle to pulmonary artery conduits. Right ventricle to pulmonary artery conduits are widely used in the treatment of severe RV outflow tract obstructive lesions, including pulmonary atresia. These conduits may be homografts or prosthetic conduits with bioprosthetic valves used within the conduit. A minority of conduits from the RV to PA may show early dysfunction because of kinking or aneurysmal dilation. The remainder will become dysfunctional over time and usually require replacement or intervention because of progressive stenosis within the conduit or at the valve and or valvular regurgitation at a mean interval of 10 to 15 years from placement. Accordingly, the 2018 Congenital Heart Guidelines say, in patients with stented right ventricle to PA conduits and worsening pulmonary stenosis or pulmonary regurgitation, evaluation for conduit complications should be performed, including fluoroscopy to evaluate for stent fracture and blood cultures to assess for infective endocarditis. That's a Class 1 recommendation. Intervention can be done for moderate or severe PR or PS if symptomatic, that's Class 2A, or asymptomatic Class 2B. Specifically, the guidelines say right ventricle to pulmonary artery conduit intervention is reasonable for adults with right ventricle to pulmonary artery conduit and moderate or greater pulmonary regurgitation or moderate or greater stenosis with reduced functional capacity or arrhythmia. That's a Class 2A recommendation. Right ventricle to pulmonary artery conduit intervention may be reasonable for asymptomatic adults with right ventricle to pulmonary artery conduit and severe stenosis or severe regurgitation with reduced RV ejection fraction or RV dilation. That's a Class 2B recommendation. That's all for Ebstein's anomaly, double chamber right ventricle, tricuspid valve dysplasia, pulmonary valve hypoplasia, and right ventricle to pulmonary artery conduit.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.